Hi, I'm Dr. Lisa Chaiken, and I'm a radiation oncologist in Santa Monica. And I work at, or will be working at St. John's Hospital starting October 1st, joining the Valley Radiotherapy Group there, and at the Department of Radiation Oncology at St. John's Medical Center.
There have been lots of new forms of technology coming out of radiation oncology. What do you think patients should initially need to know about these forms of technology?
I think all these technologies are wonderful additions to the treatment. They're allowing us to target the prostate gland in the area at risk better and exclude normal tissue that can often lead to side effects, exclude that tissue so we have less side effects. So we're getting higher dose to where we need to get the dose to the tumor, sparing our normal tissues and getting higher cure rates with less side effects. Now, there are many ways that we can approach this, and you're right, there are many initials. There's IMRT, IGRT, there's protons versus photons. A cyberknife is something more specialized to treat areas of the body in larger fractions, which is a little more experimental with radiation treatment. And there are things that we're seeing advertised on both radio and in articles on rapid arc radiation therapy to deliver IMRT in a faster, sometimes more comprehensive way. And all these are excellent options. What I would recommend to patients is that they seek treatment that is local, that is state-of-the-art type of treatment using intensity modulated radiation therapy, and to look for treatments that will be able to dose escalate, meaning giving the higher dose because of the new technology.
What we do know is there are considerable variations of outcomes depending on region and/or actual surgeon experience. We understand that is slightly less in radiation oncology. Can you talk a little bit about what the risks are and the level of variation?
There is certainly a user dependence with undergoing any of these treatments, and it is important that the physician has not only their own experience, and I've been doing IMRT since it first really became available in the late 90s, and have a large experience in how to integrate it, how to apply it appropriately with larger or smaller fields for the patient with prostate cancer. You want to make sure that the facility has the physics support and the technical support, because it is a team effort, and also that there's good coordination of care, that oftentimes patients are seen by not only myself as a radiation oncologist, but medical oncologists, oftentimes surgeons to place, not only to give their input as to treatment, but to place fiducial markers and monitoring devices during the course of the radiation treatment. So I think having coordination of care, having a good staff, and having a doctor with a lot of experience with the state-of-the-art types of machines and the physics planning behind it is really essential.
Most people have not heard the term fiducial markers, which are used in monitoring the position of the prostate in real time during treatment and actually ensuring that you are limiting risks related to movement of the prostate. Can you explain this a little more?
Since we are targeting the dose so carefully, we have to make sure that we're able to reach our target with the radiation therapy. And therefore, we go from the outside in. We try and get patients in a very reproducible position using different types of immobilization so that they get on the table the same way every day. And even with the best immobilization, we know the prostate can move up to almost a centimeter internally. So there are different ways from the outside with ultrasound and BAT, which is a way of taking an ultrasound of the prostate, to putting markers in the prostate gland. And those will tell us if the gland moves during the course of radiation, or now with a rapid arc treatment that is a full arc of IMRT radiation type of treatment, the treatment time is much faster and the movement within the fraction is much less critical. However, we do need to have markers which are placed, and we can take an X-ray or a CT type of X-ray prior to giving the treatment daily, and that way we make sure that everything is lined up exactly as it was when the treatment plan was performed, so the patient's getting very reproducible treatment. And with the newer machines, such as the Varian Trilogy, we're able to take these pictures every day before the treatment and then deliver the treatment in a very accurate and short time interval that doesn't allow for much change with intrafraction movement.
Historically, one of the downsides to radiation therapy was the amount of time patients had to keep coming back for treatments, which could be weeks and weeks. Can you talk about your expectations moving forward as these new technologies are coming available, which will allow fewer number of visits due to more concentrated doses?
There does seem to be a tendency or trials starting to look at shorter courses of treatment with larger fractions for very select patients that have very localized tumors. But that is still in an experimental phase that really has to be done on protocol at a center. It's not mainstream data yet because it really involves a lot of assumptions that we still need to prove in terms of how prostate tissue responds and how normal tissue responds. We are still looking at treatments that do sometimes run 8 or 9 weeks of daily therapy, but they're much better tolerated. The fatigue is less because the targeting is better, the radiation's better tolerated, and so patients are able to keep up their normal types of activities during this time. Patients also do have the ability to get radiation which is localized by a radiation implant, either with seeds that stay in the prostate or seeds that are temporarily put in the prostate and taken out, high-dose rate brachytherapy or implants. And these can greatly shorten the course of treatment if they're used especially alone or if they're used in combination with maybe 4 or 5 weeks of daily radiation treatment, depending on the whole plan. So lots of options that do allow us to shorten the treatment.
There are data suggesting that weightlifting, exercise, and other things can ameliorate some of the side effects of radiation. Can you tell us a little more about this?
Yes, we do like patients to keep up as normal activity load as possible. And patients especially that get an androgen deprivation treatment with radiation do suffer more muscle loss, and so lifting weights and eating a very heart-healthy diet and watching sugars and watching for other things that might, with the two treatments, create more side effects and weight gain and possible more complications. So we do encourage patients to be active, be doing weightlifting, eating a healthy diet. With the new techniques of radiation, we're seeing less rectal and bladder irritation. But sometimes we do have to modify raw fruits and vegetables. Sometimes we have people take fibers during the treatment to keep the bowel regulated temporarily to get them through the treatment. But we're finding that the side effect profile is much less, and when side effects do occur, they're usually more short-term and do not have long-lasting implications that involve more treatments or more problems later on. That we're not seeing that with the newer types of techniques.
What do you see as the greatest benefit of these new technologies for patients?
You know, it's a very exciting time to be practicing radiation oncology and very exciting for the patients because there are all of these very sophisticated and worthwhile applications of radiation using now intensity modulated radiation therapy, being able to curve the dose around the prostate gland so to avoid the bladder, avoid the rectum, try and avoid nerves and structures that may contribute to sexual function so that is given the best chance of preservation as well. And I think that patients are now at least being treated in a time where we have very sophisticated methods and that we really can get better results with less side effects. And patients just need to see their physicians and have their physicians talk with each other and come up with the best plan that's really unique to their set of criteria and what their disease shows and their workup. And there are a lot of good options where people are living longer, higher cure rates, and even with disease that's more difficult to control, still living longer with the disease is more of a chronic illness than having to have necessarily a life-threatening effect from the prostate cancer.